Right, I've been really overthinking this. We've done videos in the past where I've talked about the coronary arteries of the heart. I've talked about the nervous innervation of the heart, so how we speed up and decrease rate of contraction, force of contraction, things like that. But we've never actually looked at the parts of the heart. I kind of take it for granted really, and I really shouldn't, should I? Two things this week. My son was dissecting a cow's heart in a GCSE level biology. So that prompted me to think, that would be a good thing to do, a run through. Also, one of the courses I teach on this year, we've also been looking at the heart. They're starting anatomy, brand new to anatomy, stuck some hearts in front of them and said, what's this, what's this, what's this? And they were along the lines of, I looked at the heart a while ago, but I wouldn't mind going over it again. So that's how I'm going to approach this. I've got to not do too much detail. Don't go crazy. I guess the main aim will be to follow the blood in, follow the blood around the chambers of the heart, talk about the chambers, talk about the valves, talk about the blood vessels, talk about how the heart contracts, chuck in a few fun facts on top, something like that. Okay, so what do we got? Where do we start? Well, we might need to get rid of maybe some existing ideas about how the heart is placed in the chest. And there are a whole bunch of ways of describing the parts of the heart, but I think the most important are the base of the heart. And the base of the heart is flattish. And then we have the apex of the heart. The base of the heart then is sitting on the diaphragm, so it's quite flat. And we can see this blood vessel down here. And then we have the apex of the heart. And the apex of the heart is really, this is the tip of the left ventricle. And it's not sticking outwards like this. The apex is sticking out towards the left side of the body, to about the level of the fifth intercostal space and the mid-clavicular line, if you want to be particular about it. We can see that here. All right. Which means that we're going to look at the blood, the chambers and what have you in a moment, but that means that actually this is going to be the right ventricle. So this is very much the anterior part, and this is the right atrium. We'll work our way around though. If I put the lungs in place, that way. You took him off 10 seconds ago. You should be able to get him back on. There we go. Yeah. You can see how the lungs there are surrounding the heart. The lungs like to fill all the space that they can. Okay, so the heart's in this position. As I'm going to rotate it, try to follow your way around, but remember how it sits in the body. So these are the two blood vessels we're going to start with. So this is the inferior vena cava, or the IVC, as people like to talk about it. I love to use the longer terms because it means more. When we bandy around lots of TLAs, three-letter acronyms, people get confused really quickly. So the inferior vena cava is the major vein of the body, so it's draining blood from everything inferior to the heart, really. And it's cut off here because it's running straight through the diaphragm and then up into what we see here is the right atrium here. So that's the first chamber that blood is getting pulled into. The superior vena cava is up here. That's the superior vena cava. These are the two brachiocephalic veins coming together to form the superior vena cava. Brachiocephalic, well, brachium means arm, cephalic means head. So the two brachiocephalic veins are pulling all the blood from the head, neck, and upper limbs, right? So that's going into the top. So both of these veins are then draining all of the systemic circulation into the right atrium, the right side of the heart. When we look at the right atrium, we see that it's actually, it's not just a tube or a space or a sac. There's some interesting shapes in there. For one, well, the flappy bit over the top there is the auricle, little sacky space. We see these muscular folds in the wall. We also see these in the ventricles too. But one thing, I'll stick my finger through there. Can you see it? All right, so that there, you can see the depression. That's the fossa ovalis. In the adult, fossa, because it's just a depression, it's not a hole. In the fetus, that's the foramen ovalis, and that's in the atrial septum, septum meaning fence. So the atrial septum is the divider between the right atrium and the left atrium. In the fetus, I talked about this in another video, blood goes through that flap valve, so it can go from the right side of the heart to the left side of the heart and not bother going through the lungs. In the adult then, we have this very distinctive fossa ovalis, and very much when you dissect a heart, when you open up a heart, the fossa ovalis it stands out, it's very clear. And we can see this nicely red tinted hole here. That red hole, that's the coronary sinus draining into the right atrium. So the coronary sinus, we talked about this when we looked at the blood vessels of the heart. That's draining the blood from the musculature of the heart on the outside. And then it drains its blood into the right atrium through that hole of the coronary sinus. We might come back to that when we're looking for bits of the electrical conducting system of the heart. So the right atrium's up here, easily identifiable by these large superior and inferior vena cava draining blood into it. So the blood passes from the right atrium, from the right atrium to the right ventricle. So if we think about the heart roughly in position in the body there, do you see what I mean about how the right ventricle is the anterior part, the left ventricle here then is off to the left. So there then is the right ventricle. And there's the left ventricle, which we'll come to as we follow the blood around. So the blood flows from the right atrium to the right ventricle, and it's passing through a valve. Now, if you're trying to remember the names of these valves, the safe bet is to remember it's the atrioventricular valve, because it's going from the atrium to the ventricle. So this would be the right atrioventricular valve. It has cusps. So cusps might be the parts of the valve. On the right side, it's got 3 cusps, so it gets called the tricuspid valve as well. Now, the way I remember this is you could spell right with the letters R-I-T, which are in tricuspid, right? Yeah, the way we remember things doesn't work for everybody, but that just seems to work for me. So the tricuspid valve is on the right atrioventricular valve. Now, when we listen to somebody's heart, we hear the lub-dub, lub-dub, lub-dub sound, don't we? And the lub then is the sound of that valve, or the 2 atrioventricular valves snapping shut when the atria have squeezed their blood into the ventricles, and then the ventricles squeeze and those valves get snapped shut. We can see some other structures in here. We can see that the valves, the cusps of the valves have fibrous kind of like guy wires coming from them. And these get called the chordae tendineae, or more sensibly tendinous cords. For some reason I've got the Latin in my head. I always call them chordae tendineae. Tendinous cords. And you can see the musculature of the right ventricle has got these little like nipply bits sticking out from it. And they're like papillae. These are the papillary muscles. And the purpose then of the papillary muscles and the chordae tendineae, those guy ropes stop that valve from inverting, so the cusps of the valve don't get blown into the right atrium, in which case they wouldn't work and it would be useless. It just flaps shut. Now, a couple of notes on this. One, the heart is largely muscle. It has 3 layers of tissue. We have an endocardium lining the internal surface of the heart. This is largely endothelium, like we see in blood vessels, with some connective tissue kind of holding the sheet together. Then we have most of the heart is made up of myocardium, and that's this cardiac muscle, which is obviously, as I'm sure you're aware, it's a specialised muscle. It's striated muscle, but this is a muscle that has to keep contracting forever until you die, unlike pretty much all of the other muscles in the body. The cardiac muscle cells are all connected to one another, which means that an electrical impulse can be transferred across the muscle wall, and this is what we see in the atrium. We'll talk about that later. But it means we can synchronise contractions of regions of the heart, which is important to the function of the heart. So that's the myocardium, and then the heart is covered with a thin layer of epicardium, and the epicardium is the heart is surrounded by pericardium. There are 3 layers of pericardium, and that's a different topic. But the visceral pericardium that's actually lining the covering of the heart is the same thing as the epicardium. Does that make sense? Where the visceral pericardium is covering other parts, like the great vessels, it's not called epicardium. So I don't think there are 4 layers, there's the 3 layers there. Okay, so we keep following this through. What can we see? Right, well, imagine that's still there, right? This then, this here, this is the interventricular septum. So between the two atria, we've got the atrial septum or the interatrial septum. Between the two ventricles, then similarly, we have the interventricular septum. Now, the interventricular septum actually has two parts. Most of it you can see is very muscular. This is the muscular part of the interventricular septum here. But the most superior part, closest to the great vessels that are leaving the heart, this is a membranous part of the interventricular septum. There's some good embryology as to why this occurs, and it relates to how the great vessels formed, but it means that the interventricular septum is a little different along its length. If a baby has a ventricular septal defect, that's where it's most likely to be, close to the great vessels, and in that the kind of a gap there where the membranous interventricular septum should be. But you can see how muscular this is. The interventricular septum is largely part of the ventricles, and it's going to contract. So blood fills the right ventricle, and when the right ventricle contracts, it closes the right atrioventricular valve, and blood is instead pushed through the pulmonary valve, through the pulmonary trunk, because of the direction the valves are organised in. So the pulmonary valve gets called a semilunar valve, but it's got three cusps, so don't get confused by that. Semilunar, half moon, right? The reason it's called a semilunar valve is what we can't see here is that on the other side of that cusp, the valve is kind of like a curved bag. So when blood gets pushed, when the right ventricle contracts and blood gets pushed up, the bag gets pushed aside and blood goes out. But when the right ventricle starts to relax and blood falls back down again, it fills the bag of the semilunar valve, just called semilunar because it's like a half moon shaped bag, and that then falls shut against the other two. So we have three semilunar cusps, and they all fill with blood, snap shut against each other, and the valve is closed. That's the weight of the blood essentially getting pulled back down the pulmonary trunk that's closing it. So with the lub-dub sound then, the lub sound is the atrioventricular valves snapping shut. The dub sound are the semilunar valves of the pulmonary valve and the aortic valve snapping shut. Lub-dub, 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 right? And then blood gets pushed up the pulmonary trunk, and then the pulmonary trunk splits into, but this is the left and this is the right pulmonary artery. Of course, these are coloured blue on this model because they're poorly oxygenated. The blood has come from the superior and inferior vena cava, so it's come from the body. It's poorly oxygenated, high in CO2. So the blood is blue, and it goes out of the pulmonary trunk and into the two lungs, where the CO2 will be gotten ridden of them, and the blood will become highly oxygenated, and the blood will become red as the hemoglobin changes, right? So this is the red we see here. These then are pulmonary veins. We see if we cut this really close to the heart, we still see two pulmonary veins on the left side and two pulmonary veins on the right side. So if I'm going to look at the posterior part of the heart, this then is the left atrium, and the two pairs of pulmonary veins are going to drain blood into the left atrium, and this is going to be highly oxygenated blood. So on the left atrium we can see the other side then of that fossa ovalis, or oval fossa, and then we can see this valve here. So this valve then is the left atrioventricular valve, and the left atrioventricular valve only has two leaflets, right? So it's kind of that shape. So as blood goes through it, it opens, and as it closes, it snaps shut like that. Because it has two leaflets, it looks a bit like a bishop's mitre. I don't know if you've ever seen a bishop's mitre. If you haven't, you should Google image search that. And that's why it gets called the mitral valve, and also the bicuspid valve, because it has those two cusps, or two leaflets, or two parts of the valve, right? And again, we see those tendinous cords and the papillary muscles tying all that down. The blood goes from the left atrium, we can see another auricle here, from the left atrium through the left atrioventricular valve into the left ventricle. And we notice normally that the left ventricle has a much thicker muscular wall than the right ventricle, because the left ventricle, when it contracts, it's going to push blood out through the aorta, so through the aortic valve in there, up through the aorta, and then from the aorta, which is a massive, great big blood vessel, that's going to go all the way around the body. So there's a lot more pressure from the left ventricle required to push the blood all the way around the body, and essentially back into the heart, kind of. That's physiology. Ain't doing physiology. Don't get paid for physiology. Okay, now a couple of notes on all that. The fibrous skeleton of the heart. So it's not just muscle, but there's a fibrous skeleton. These are largely fibrous rings, so fairly tough connective tissue rings around the valves. And can you see that the valves are all kind of roughly on the same plane, right? So imagine those valves have this fibrous skeleton around them. The purpose then of the fibrous skeleton is largely to support the valves, so that as the heart expands and shrinks and stuff and contracts and what have you, the valves don't change shape, because if the valves changed shape, they wouldn't work. So the valves are held, they're anchored in place by this fibrous skeleton. The other thing the fibrous skeleton does is it insulates electrically the atria from the ventricles. A couple of other things to consider. The main thing then is the electrical structures in the heart. There is a nice model, I think, which has got a transparent heart and shows all the nerves on it, but I haven't got one of those, so you're going to have to make do with my description. The other thing we should consider is what happens if the valves don't work properly. Can you see how, here's the right atrium here and the right ventricle. The auricle flaps over it, but there's an atrioventricular groove running around here, which has got the coronary arteries and some of the cardiac veins within it, right? So there's an atrioventricular groove, and also, so you can tell where the right ventricle is from the left ventricle, because there's this interventricular groove here. There's an anterior one, which we see these blood vessels running in, and there's also a posterior one here. See how flat this is? Whenever we take a heart out of a body, or we look at the heart in the body, it's completely covered in fat. So to see all these structures, we have to dissect away the fat. So even if you're a super skinny person, you've got, you know, a nice amount of fat protecting your heart and covering all this sort of stuff up. But there are those grooves there. Now, okay, electrical system of the heart. The sinoatrial node, SA node, atrial gives you a clue as to where it is. The SA node, the sinoatrial node, gets described as the pacemaker of the heart. This is a site of, there's a collection of neurons here which can initiate an electrical pulse all on their own. So it is possible for the heart to be removed essentially from the rest of the body, and the SA node will cause the rhythmic contractions of the heart to keep going nonetheless. So that's the sinoatrial node. And then the parasympathetic and sympathetic nervous system can act on the SA node to sympathetic increase and parasympathetic decrease the rate of contraction and the force of contraction. So the SA node is, if here's the superior vena cava and here's the right atrium, the SA node is up here somewhere. So it's close to where, it's in the atrium, in the wall of the atrium, and it's close to where the superior vena cava enters the right atrium, and it's kind of lateral and around here, right? So it's up there in the wall there. Now, the SA node then triggers an electrical impulse, for a better description, and that electrical impulse will cause the cardiac muscle of the atrium to contract, and that wave of impulse will spread through the muscular wall of the atrium. It'll spread from the right atrium to the left atrium, so both the right and left atria will contract together as that electrical impulse travels through the muscle of the atria. And then, down here, there's another node, the atrioventricular node, or the AV node. Where's that? Well, the AV node then is going to be kind of between the atria and the ventricles. Well, really, it's in the atrium. It's in the right atrium again, and it's in the interatrial septum. And down there, where that red spot is, we can see where the coronary sinus opens into the right atrium. The AV node is right next to it, so it's a little bit more medial in the interatrial septum. The AV node is just in there. Now, I said that the fibrous skeleton supporting the valves is also a bit of an electrical what's the word? Insulator. So the fibrous skeleton is a bit of an electrical insulator between the atrium and the ventricles. So what happens is when that electrical impulse, when that electrical activity gets to the AV node, now the AV node, that electrical impulse isn't going to pass straight from the atria to the ventricles. It's going to pass into the AV node, trigger the AV node to do its thing. Now from the AV node, we have what we used to call the bundles of His. We now call it the atrioventricular bundle. So we have neurons extending through the fibrous skeleton into the ventricles, and they're in the interventricular septum, in the membranous part. Now in the membranous part, that bundle passes down, and then as we get to the muscular part, it splits into two, one for the left and one for the right ventricle, right? So the AV bundle splits into two, descends down the muscular part of the interventricular septum, and then it connects to what have been called Purkinje fibres, now get called subendocardial fibres, which is, to be honest, a much more sensible term, subendocardial, below the endocardium. And those subendocardial fibres then project around from the septum here, project around the ventricles and send that electrical activity into the musculature of the ventricles, causing them to contract. So by doing that, we then have this organised contraction of the atria, then the ventricles. Now, when we think about contraction, you probably think about just squeezing, right? But in fact, the muscle arrangement of the ventricles is kind of like, it's like two helices, right? Twisting around. So when they contract, really, they kind of more ring the heart. So it kind of rings it and shortens it, and then lengthens the ventricles, and that's squeezing the blood out of the ventricles into the pulmonary trunk and the aorta. So we have the atria contract, push the blood into the ventricles, ventricles twist and contract, push the blood up through the pulmonary trunk and the aorta, and as they relax, then the atria then are squeezing and pushing the blood into the ventricles and pulling it in, which means that the pressure in the ventricles gets really high, the pressure in the atria gets quite, well, it goes up and down, doesn't it? Again, okay, physiology, stop, you're going to get yourself into a mess, don't do it. Right, so I think we've covered the necessary anatomy of the heart. A couple of clinical questions there. What happens if the valves don't work properly? Damage to the valves could be caused by endocarditis, could be caused by a heart attack, could be caused by congenital conditions, all sorts of things, right? A heart murmur. A heart murmur often refers to, the turbulent sound you hear, which is often related to valves. Sometimes they happen in kids and they have no effect at all, and everything changes. Right, so, well, if the valve doesn't close properly, for example, if the left ventricle contracts, pushes blood up into the aorta, but then the aortic valve doesn't close properly, it means that some of the blood from the aorta is going to fall back into the left ventricle, and so the left ventricle is going to have to work harder, and this is regurgitation, right? The heart is going to have to work harder to compensate for that faulty valve. The other thing that can occur is if a valve doesn't open properly, then we get stenosis, so we don't get the full opening of the hole we expect. So with stenosis, again, the heart has to work harder to push the blood through that narrowing. So it's important the valves work normally, and if things start to break, then this can change the nature of the heart, change the structure of the heart, and lead to other problems that need to be fixed. So if you have what might be called an incompetent valve, or regurgitation, or a leaky valve maybe, then because the heart has to work harder, you might find the patient is getting out of breath easily, more swelling around the feet and the ankles because the fluid isn't being returned from the extremities as effectively. And if you listen to the heart, you might hear a murmur, you might hear that regurgitation, that noisy flow of blood, which is unusual. What about a pulmonary embolism? What effect might a pulmonary embolism have on the heart? Now, the lungs and the heart are closely connected, right? And of course, the right side of the heart, its job is to push blood into the lungs, and then the left side of the heart pulls blood back from the lungs. So if you have a pulmonary embolism blocking one of those arteries, well, that means the right side of the heart is going to find it harder to push blood into the lungs, because one of those arteries, maybe one of the big arteries, is going to be blocked. And then it's also going to be harder for the heart to pull blood back into itself from the lungs, because there's going to be less blood going into a major part of the lungs potentially. So with a pulmonary embolism blocking one of the pulmonary arteries, then you'll get the expected symptoms of pain, shortness of breath, pain in the back, that sort of thing, maybe rapid breathing, but also a rapid pulse, because the heart has to compensate for that blockage and still pump the blood around the body, but it's having a harder time of doing it because you've blocked part of the pump, right? Pulmonary embolism in the heart. Yeah, whenever we think about the circulatory system of the lungs, we should always link the lungs and the heart together. Right, there you go. How's that? Have I done too much? Have I done too little? Doesn't really matter. But that is the anatomy of the heart. So we've looked at the chambers, we've looked at the major blood vessels, we've looked at the valves, we've followed the flow of blood around the heart, we've talked about the septa, and we've talked about some other interesting bits and bobs of the heart, which are generally important to most people in the general anatomy of the heart. Done. Right. That should have been easier than it was. Heart anatomy should be off the top of my head, but I've just been overthinking it. Right, see you next week.